welcome everyone to what I hope is going to be a fantastic seminar about the really large research programme, the QUOKKA Quality of Life in Kids research programme that I've been following with some interest really to see what's going to be produced as part of the project, and obviously so much has already been made available. So we've got a wealth of speakers today, which is fantastic to see. So to start with, we have Professor Nancy Devlin, who's Professor of Health Economics at the University of Melbourne and Director of the Centre of Health Policy there. Then we've got Kim Dalziel, who's Professor and Head of the Health Economics Group and Deputy Director of the Centre for Health Policy at the University of Melbourne in Australia. Then we're going to have Christine Mpundu Kambwa, who's a health economist at Flinders University in Australia. Then we're moving on to Alice Yu, who's a research fellow in health economics at SHARE at the University of Technology, Sydney in Australia. And then finally, we've got Tessa Peasgood, who was at University of Melbourne for a lot of the research as it was conducted, but now who's a senior research fellow at the University of Sheffield. So I'm really pleased to see everybody here today, and I'd like to pass over to Nancy. Thanks.
Thank you, Donna, and thank you, Di. It's great to getting this opportunity to present our work to the SIG. Very pleased to be here. We're going to give you an overview of QUOKKA's research tonight across our entire research program. So it's necessarily going to be at a fairly sort of high level and just with snippets to give you illustrations of our results. But hopefully we'll give you enough of a flavour of what we've done that you'll be able to sort of follow the publications as they come out, and we can tell you a bit about things that we've published already. Next slide. So one of the things we did right at the beginning of our project was to try and get a baseline for what the state of play was around the use of health-related quality of life in children by the PBAC, given that QUOKKA is based in Australia and the PBAC is our decision maker here in HTA. And so what we did was have a look at the public summary documents, the PSDs, for technologies that were aimed at children or for whom children were a beneficiary. And what we found was in those instances that only 6% of those public summary documents used instruments that were appropriate for children. There were adult measures used in many cases, and half of the documents had no information on the source of utilities at all. So a real mixed bag of uncertainty about what was done, and where there was information provided, clearly some of the instruments that are available are simply not being used. So overall, the submissions involved inconsistent approaches, use of adult measures and weights, and really substantial gaps in evidence. So, and this isn't specific to PBAC, by the way, so we're not here being critical of PBAC. You may be aware of the fact that similar sorts of reviews have been done around NICE decisions concerning children and around infectious diseases generally, and all of them find that same picture. So QUOKKA is partly a response to a call from the PBAC that came through to the Medical Research Future Fund, which put out a targeted call in 2019. And we were delighted to be receiving funding from that. We also then supplemented that with a smaller HRQoL grant, for which we were very grateful to be able to do some extended work around the EQ5D instruments. Next slide. So we've published some content already to provide, again, something around that, what the starting point is. So the review of PBAC decisions has been published, and as well as that, we did these systematic reviews in conjunction with TORCH, which is another research program being run in Australia. And you may be familiar with these. So there was a systematic review of childhood PROMs that was published last year. We did a systematic review of valuation methods that have been used to generate utilities for childhood PROMs, also published in Pharmacoeconomics last year. And we also published, or have had accepted for publication, but it's not yet out, a systematic review of the social value of a child QUALI. And that informs one of the projects that we'll be looking into today. And then finally, we've also produced, partly in response to the very poor reporting that we found when we reviewed the research and decisions using evidence on childhood health-related quality of life, we've developed a reporting checklist for child health-related quality of life valuation, which will be coming out soon. So here's an overview of how QUOKKA is put together overall. So the papers that I've talked to you about so far are sort of that project kickoff activities where we were trying to thoroughly and systematically document the current state of play. And then we moved very rapidly in our project into 6 projects, which are not necessarily sequential. So the first one is what we call our PMIC study. So that's our Paediatric Multi-Instrument Comparison study. And that's a comprehensive database of patient-level data where we are trying to generate evidence on how the alternative paediatric instruments which exist, how they compare in terms of their psychometric performance. Project 2 is around understanding the differences between self-report and proxy report, given that that's absolutely crucial when you're talking about measuring health-related quality of life in children, and also how proxy report might be strengthened and how self-report might be strengthened by experimenting, for example, with pictorial approaches to the measurement of health. Then we have a group of 3 projects, 3, 4, and 5, which are all exploring different aspects of how we preference weight or generate values for health-related quality of life in children, beginning with a very extensive qualitative research study, Project 3, going into a large-scale DCE study with multiple arms in Study 4, and all of that will culminate in a new value set for Australia. And then last but certainly not least was a project where we undertook a present trade-off study to try and understand whether the Australian general public felt that there was a basis for prioritising gains in child QUALYs as opposed to adult QUALYs. And so what we've got today in our presentation is a little touch of each of those, and then hopefully we'll have time for questions at the end. So with that, I will hand over to my colleague, Kim Dalziel.
Excellent, thank you. So I'll be speaking about the Paediatric Multi-Instrument Comparison study. I would like to acknowledge the other investigators, Nancy Devlin, Brendan Mulhern, and Harriet Hiscock, and also acknowledge Renee Jones, who did a lot of the project management on this to collect this data and then into her PhD to keep analysing. So this is an overview of the Australian Paediatric Multi-Instrument Comparison study. There's a code there that links to our protocol. In summary, we've collected data on 6,787 children, and just over 1,000 of these are from a major tertiary paediatric hospital. We have a dedicated online general population sample and then some common conditions which were sampled in quotas, also online, and aiming for 400 children per condition across 11 dedicated conditions. We gave the survey to parents initially. They completed the demographics. If they deemed that their child was able to complete the questionnaire and they were over 7 years of age, then the child could self-complete their own quality of life, and at that point the survey was handed over. In our survey, 57% of children self-reported. We went from age 2 right through to 18. And then the majority of the sample, 4 weeks later, they completed the quality of life instruments again. And in a small subset, a test-retest sample, they completed it 2 days later as well. The core set of instruments was determined based on a systematic review, those systematic reviews of the literature to see where we had the best existing psychometric performance, but also gaps for certain conditions, but also what was acceptable and commonly used in the Australian context. So the EQ5DY, 3L, 5L, CHU9D, and PEDS-QL made it into the core instrument. We had 3 other instruments of interest, but our consumer advisors were worried about the burden of our survey, so they got pushed back into a randomised block where participants would receive 1 out of those 3 instruments from the HRQoL, PROMIS 25, and HUI. And then the 11 conditions, they also received a condition-specific measure and some self-reported severity alongside. These are the psychometric analyses that we performed, and the main thing to point out here is that there's a really extensive psychometric analysis guide, and that's available through the QR code, and that's publicly available now as a resource for anyone who might want to look at how these decisions were made, and it could be a good starting point for others seeking to do these types of analyses too. So I'm going to give a really quick whirlwind through some of our headline results. So this is firstly for children aged 5 to 18 years. We've got 6 of the instruments measured listed here. We firstly looked at the distribution of responses to see if there was any evidence of ceiling effects for any of the instruments, and this was defined as more than 15% of participants reporting no problems in all the items, and in a sample of children with special healthcare needs where we would have expected them to have quite a lot of problems. But it was really only the EQ5-BY3L that was greater than that ceiling effect threshold. All of these instruments in this age group showed good evidence of known group validity, and they all had large effect sizes that were statistically significant. And this was the ability of the instrument to differentiate for children with and without a special healthcare need. We do note that the results vary by subgroups, child age, and whether it was proxy or self-reported. So it's important to consider that granularity of the evidence as well, which you'll find in our manuscript. This is the evidence for that same age group, 5 to 18, about how children responses changed over time. So on the left, we've got the test-retest reliability, and this was in children where the parents said there was no change in that child's health. All of the instruments showed a good test-retest reliability, moderate or good. And I think the main difference here that stood out was perhaps the CHU9D being slightly weaker test-retest reliability in this sample compared to the other instruments. That flips when we move across to the right, responsiveness. So this is now children who the parents reported that they had improved or worsened the child's health, and it was the ability of that instrument to pick up that change. So now what we see is 3 instruments, Y3L, Y5L, and CHU9D, all had statistically significant standardized response means, meaning they could detect that change, noting that the size of those effects is quite small. And I guess the other thing to note is that this sample is not a sample that we selected because they were receiving an intervention per se. They may have, but we're assessing responsiveness on the basis of their parents reporting a change, which is a reasonably weak amount of change. So we would expect this to represent a minimum of the responsiveness for these instruments. HRQoL showed an inconsistent result with ability to detect worsening health but not improving health. And then the HRQoL and HUI were determined to have inadequate sample sizes to draw a robust conclusion. Now, just very quickly on the younger children. So these were the children aged 2 to 4 years. We measured their psychometric performance of the HRQoL, a version of the EQ5-DY that was adapted, that its wording was just minor modifications to make it more suitable for this age group. The CHU9D for under 5s, the QUI, and the EQ tips. So in terms of known group validity, all of these instruments, aside from the CHU9D, were able to differentiate between special healthcare needs and no special healthcare needs with large effect sizes. And the CHU9D could detect the differences with medium effect sizes. And if we look at the differences between parents reporting poor or fair health versus good or excellent health, now all the instruments apart from the HUI were able to do that with large effect sizes. Moving on to responsiveness, this is a little bit harder to interpret, but what I'm concluding is that children who improved health, stayed the same or worsened, the direction of all of those effects is in the right direction that we would expect. Now we're seeing quite small effect sizes and the difference across the instruments, and only the adapted Y5L in improving health having a statistically significant result. And we've got lots of small and trivial effect sizes. So this is childhood, so children with childhood conditions aged 2 to 18. We've got 7 conditions represented here, and just looking at the ability of the instruments to detect children with and without that condition. And I've got 4 instruments listed, and the important thing to note is really some quite strong differences in size, the effect size across conditions. So we saw asthma and tooth problems with medium effect sizes compared to the other conditions with strong effect sizes. Not so much difference across the instruments, but more so differences across conditions. We had quite different results for some of it for our samples of children with mental health concerns, and I'm just showing you one for today, but this is the sample with children with ADHD. And this is a different result than we see for other conditions or across the total sample, which is here. Here we see the HRQoL and the CHU9D with the strongest effect sizes for differentiating children with and without clinical symptoms of ADHD, and the EQ5DY, well, both EQ instruments and the HUI with smaller effect sizes. So showing some differences between the instruments. In terms of complex conditions, this is children aged 5 to 18. This was a sample who was selected because they were very complex. They were born extremely premature with rare genetic conditions, or they were sampled from the ICU or emergency departments. So this is a sample selected because we expected their health to be changing more. And the main thing that we're seeing here is in terms of responsiveness, this is the first time across any of our analyses that we see a large standardized response mean. Here I've got medium, the EQ5DY5L, but if we move to just that sample from the ICU and short stay unit, that turns into a large effect size. And finally, I just wanted to show you the results of the parent. So in response to our consumer advisory group, they felt it was really important that we also measure the parent quality of life in this study. So we added in the EQHWB. This graph just shows the raw responses to the quality of life measure across the domain. The dark blue is a sample of the general population without children with conditions, and the light blue is the sample of children with health conditions. In every domain, we're seeing worse quality of life for the parents of children with health conditions. And the largest difference just on the raw scores here is in that domain of exhaustion. And interestingly, we had a look at the ability of the parents' health-related quality of life to differentiate between a known group of children with and without special healthcare needs and with and without chronic conditions. The EQHWB was able to do this with medium effects, with moderate effect sizes, so that is showing up in the parent quality of life, the impact of the child's condition. And just to finish off, there's many papers coming. We have a special supplement coming in pharmacoeconomics, so keep an eye out for that. But we've also been mapping out an international protocol to extend this multi-instrument comparison study across other countries, and we have initial interest from 10 other countries. We've been putting together a proposed core data set of what might be some common data that could be collected across all those countries. If you have an interest in this study, then please, I'd be super happy to hear from you. So over to Christine.
Thanks, Kim, and welcome everyone attending this presentation. Today, I'm excited to share insights into QUOKKA Project 2, which is focusing on strengthening measurement of pediatric health-related quality of life, specifically looking at child self-report versus proxy-report. Next slide, please. Before I go any further, I would like to acknowledge the investigators on this project, whose names are on the screen. And I'd also like to extend my acknowledgement to our dedicated PhD student, Diana Canna. Next, please. So Project 2 is a program of work with 6 sub-studies, and there are 3 empirical studies, 1, 2, and 3 at the top. And then we have 3 systematic reviews. Now, in the interest of time today, I will only present key findings from the 3 empirical studies, and I will present a QR code for you to access the systematic reviews that have been published. Pretty much all 3 of them have been published. And so, yes, I will provide that QR code for you to have a look at those. Next slide. Oh, yes, thank you. No, the slide before. Sorry, Kim, slide before. Yes, brilliant. Thank you. So study 1 explores child caregiver agreement for a range of pediatric health-related quality of life instruments. Now, in this study, we had 845 child-parent dyad complete online interviews, and their ages of the children was 6 to 10 years. Data was collected at 2 time points. That was baseline, and we had a follow-up survey administered 2 days after baseline. The instruments we used to collect data on the children was the EQ5DY 3L, the EQ5DY 5L, the CHU9D, Child Health Utility 9 Dimension, and the Pediatric Quality of Life Inventory PED score. We also collected quality of life data on the caregivers, and we used the EQ5D 5L and the EQ-HWB. Next slide, please. Now, some preliminary results from some of the instruments that we've analyzed, and we have the EQ5DY 3L and 5L childcare agreement results on the screen. And for these, we looked at the dimension scores, and these were assessed using the GWETS agreement coefficient, GWETS AC1. We also looked at the percentage agreement for the dimension level responses. And what we found was that there was good agreement between child and caregiver assessments for the Y5L and the Y3L. And the percentage agreement was similar for both instruments. We also found that the highest agreement was on the physical dimension, mobility, being 96% on the Y3L and 95% on the Y5L. We found relatively low agreement on the psychosocial dimension, feeling worried, sad, or unhappy, with 77% and 72% on the Y3L and the Y5L, respectively. Next slide, please. We also looked at the VAS scores for the parents and the children. And so we have on the vertical axis the child EQ5D VAS scores, and the horizontal axis we have the parent EQ5D VAS scores. And we have the scatter plot and an upward sloping trend line depicting the positive relationship between the child and the parent scores. And when we looked at the VAS scores in terms of agreement, which we assessed using the intra-class correlation coefficient and Lin's concordance correlation coefficient, we found a value of 0.60, denoting good agreement. Next slide, please. Now, I will present a bit of the results from the mixed method study, which was study 2. Now, this study focused on assessing the validity of children's self-reports compared to proxy reports in evaluating health-related quality of life. We conducted face-to-face semi-structured interviews with a community-based sample of 85 children, ages 6 to 12, and their parents. The children self-reported their health-related quality of life on the EQ5DY 3L, the CHU9D, and the PED score. And we collected the parents' health-related quality of life using the EQ5D 5L. Next slide, please. Now, some of the results we found, so we looked at the agreement between the children and the parents for the CHU9D and the PED score. And what we found when we looked at the utility scores for the CHU9D and the PED score using the correlation coefficients, we found that they were both low. So for the CHU9D, it was 0.28, and for the PED score, it was slightly higher, about 0.39. Now, in terms of agreement, the highest agreement was observed for the CHU9D in the SAD dimension, with a GWETS AC1 of 0.83, and with the least agreement in the tired dimension, GWETS AC1 of 0.31. And when we looked at the PED score scores, they showed a higher agreement on the physical dimensions than the psychosocial dimensions. We also noted that age impacted the PED score psychosocial agreement, with older children aged 8 and above showing lower agreement. Children ages 6 to 7 showed similar agreement levels to the older children on the CHU9D, suggesting that younger children have the potential to reliably self-report their health-related quality of life. Next slide, please. Now, as part of the mixed method study, we also looked at some qualitative analysis. And in this analysis, we looked at the results of some retrospective think aloud method that we used when we administered the EQ5DY 3L to the children. Now, this was a subsample of the 85 that we had looked at, and we only looked at 39 of the children. Of these, we found that 46% experienced response issues, particularly in the younger age cohorts, 10 and below. Now, using Tarango's framework, we categorized the response issues according to recall, judgment, and comprehension. And we found that recall issues were mostly in the 3 dimensions: feeling worried, sad, or unhappy, having pain or discomfort, and doing usual activities. Then we noted that the majority of comprehension issues were in the having pain or discomfort dimension, whilst most of the judgment issues were identified in the doing usual activities dimension. Next, please. Now, in terms of the qualitative findings, we found that children often conflated health-related abilities with non-health-related factors or limitations, such as walking about, looking after myself, and doing usual activities dimensions. Now, when you look at some of the responses that are in the yellow boxes, for instance, participant number 4, aged 11 years of age, the response was, I have some problems walking about. That was on the EQ5DY 3L. And the reason the child gave was, I can't be independent all the time. I have to have people help and I have to have help from people at times. Another response that showed the conflicted health-related abilities was that a child aged 9 years of age, which was participant 67, and they gave a response of, I have some problems doing usual activities. And the reason was because I get distracted a lot. Now, all these responses and the reasoning behind it raises these issues of conflation in health-related abilities. And that's not the reasoning that you would expect when a child is responding to the EQ5DY. Next slide, please. Other things that we found in terms of the qualitative results was that children misunderstood the term discomfort, and they often associated it with emotional pain. And we also found that the children mentioned episodes of pain and anxiety from a past outside of the recall period. And the responses and the reasoning have some examples in the boxes there, which show some of the issues that we've highlighted around misunderstanding the terms. Next slide, please. Now, study 3 is an exploratory study exploring the development of an enhanced child health utility 9 dimension to include pictorial and audio content. Now, as part of this study, we conducted 14 face-to-face interviews with children, and these were aged 6 to 12 years of age. These children had chronic health conditions and disability, including ADHD, autism spectrum disorder, and physical disability. As part of this enhancement of the CHU9D, we also had expert discussions with clinicians at one of the disability services, which is the leading disability service here in South Australia, Navita. And we had extensive discussions around the instruments and their thoughts around the pictorial content and audio content that we included. We also collaborated with an animation company here in Australia, South Australia, and they provided us with an animator. And this animator we worked with as part of this development of the pictorial and audio content. Next slide, please. So some of the things that we did as part of the development process was to develop characters for the dimensions and develop characters for the pictorial response options. And then we conducted semi-structured interviews with the pictorial and voiceover content to enhance the CHU9D text format. Now, as you can see there, we have 2 formats of response options. We have graduated circles and smiley faces. These response options we identified through the literature search we did as part of a systematic review that we've published, which you can access on our website. Next slide, please. We also presented to the children some of the pictorial illustrations that the animator from the film company developed. And so that is the worry dimension. So ranging from I don't feel worried today through to I feel very worried today, with the 5 response options, each having pictorial depictions. Next slide, please. This is another example of the cartoons designed by the animator, and this is for the dimension daily routine, and pretty similar to the worry dimension. We have the 5 response options, each with a pictorial depiction. Now, initial findings from this study is that the majority of the children preferred the CHU9D in pictorial format compared to the original text format. And the children reported finding the pictorial formats easier to understand than the text. Next slide, please. Now, in terms of the next steps for Project 2, we plan to replicate the study to investigate whether pictorial enhancements can extend the self-report age of the EQ5DY in children 4 to 7 years of age. And we also will continue to test the CHU9D pictorial enhancements in children, looking at various health conditions and disabilities, as well as looking at populations such as culturally and linguistically diverse children. In terms of updates, you have the QR code there. You'll be able to access all the new developments, all the publications that have been produced from Project 2. Thank you.
Great, thanks, Christine. So now I'll be talking a bit about Project 3. So I'm presenting Project 3 on behalf of my collaborators, in particular Yiting and Mina, who has been helping out with the data analysis, as well as Richard, Debbie, Rosalie, Nancy, and Brendan. Next slide, please. So firstly, I'll provide a bit of background and the motivation behind Project 3 before moving on to talk a bit about the methods and the work to date. I'll then present some of the findings we have before moving on to next steps and discussion. Next Yeah. Next one. So project 3 is looking at a qualitative exploration of DCEs as a method to value health-related quality of life. So we use DCEs to obtain value sets for the calculation of QUALIs, but there has been suggestions in the literature that adult and pediatric health-related quality of life is actually valued differently. There's also been debate about methodological decisions we make in DCE choice tasks and their potential impact on obtained value sets as well. Next slide. So project 3 is really trying to address some of these issues. We're interested to understand how do adults and adolescents actually value pediatric health-related quality of life? Are there any differences in how they approach these, pediatric health-related quality of life? Does variation in DCE choice tasks impact on decision-making? And in particular, we're looking at 3 types of variation. So varying perspective, choice task format, and the health-related quality of life instrument described in choice tasks. Next slide. So methods and work to date. So in general, in terms of how we actually conducted this study, so it was semi-structured interviews. So interested respondents are first asked to complete a general demographic survey and to choose their interview time. All the interviews were conducted online via Zoom. So in the interview, respondents are asked to complete an online survey with 8 to 9 choice tasks while sharing their screen, and also doing something called a think aloud exercise, where they're asked to verbalize their thinking process as they go through the survey. Respondents then will then be asked a series of pre-planned questions related to the survey. So then afterwards, the interviewers will then listen to the recordings and look at the transcripts and summarize the findings, in particular, summarizing the responses to the pre-planned questions. And in terms of the think aloud, summarizing the information according to some data points for consideration based on the aims of our study, in particular, looking at things like, how do respondents actually approach the choice task? Are there particular attributes that they consider more important? And when they see different types of choice task format, how does that impact on their decision-making process? Next slide, please. So we did take a staged approach to interviewing. So what we mean by that is that the interviews were conducted in batches or rounds. So we have 6 rounds of interviews in total, pilot round and round 1 to round 5, and round 5 is currently ongoing. But as you can see, we varied different aspects, and the aspects that were varied did depend on the round of interviews. So you'll see that choice task format was always varied in the different rounds of interviews, as that was a point of interest. And in the pilot round and round 1, we also varied the perspective respondents saw. So respondents saw some choice sets where they were asked to imagine themselves, and some choice sets where they were asked to imagine a 10-year-old, for instance. In round 2 and round 3, respondents saw a choice task described by different health-related quality of life instruments. And round 4 and 5 was kind of a step away in the sense that we were focusing specifically on the EQ5D-Y5L and looking at varying presentation style. Next slide, please. So today, I'll be presenting some of the results from the first 58 interviews. So that was from the pilot round, round 1, round 2, and round 3 of interviews. And in particular, looking at the 3 aspects that were varied in the choice tasks. So choice task format, perspective, and the use of different health-related quality of life instruments. Next slide. So there were 58 respondents in total over these few rounds of interviews, and this did consist of a range of age groups. So we did make sure to target respondents between the ages of 12 to 14, 15 to 17, and then 18 plus was a mix of parents and non-parents as well. Next slide. So who conducted the interviews? So I myself was involved in the interviewing process for the adult sample for a few of the rounds, but we did have an external company help us out with recruitment as well as with interviewing as well. In particular, Youth Insight was brought on as they have the relevant knowledge and the relevant experience in interviewing and conducting qualitative research with young people. In terms of how we analyze the data, so 2 project team members were assigned one topic to look at, and basically each of the project team members would go away, figure out what they thought were the key themes, and then they would meet and resolve any disagreements they may have about the themes and come up with the final themes. Next slide, please. So now let's talk a bit about the results. So firstly, looking at perspective. So what perspectives were respondents asked to imagine? So in some choice tasks, some of the respondents were asked to imagine themselves and then to select the health scenario or the health state that they would prefer to live in. And in other choice tasks, they were asked to imagine a 10-year-old and to select the health state that they would prefer for that child. Next slide. So when it comes to imagining a 10-year-old, what respondents imagined does vary, although what they imagine does tend to fall into 3 main categories. So this includes imagining themselves as a 10-year-old, imagining someone they know, perhaps their own child or perhaps a sibling, for instance. And there were also many respondents that just said that they imagined a generic or hypothetical 10-year-old, including a few people that did actually say they imagined a clinically ill child, for instance. Next slide, please. So we also asked respondents, what they thought was important for a 10-year-old child, and also based on evidence from the Think Aloud section as well. And many people mentioned that they would prioritize a good quality of life for a child. They also thought that mental well-being was an important factor to consider. Being active was something they thought was very important for a 10-year-old child. And for instance, things such as related to being independent became less important. So many respondents said, things like washing or dressing became less important to them. Next slide, please. So we also asked respondents in the pre-planned questions whether their responses would change or their thinking would change if we asked them to imagine someone younger or older than 10. And it was interesting to note that for someone older than 10, both the adolescent and adult sample did say that they expect someone like that would have better self-awareness and better emotional coping mechanisms as well. Next slide. So in general, what was found in terms of perspective is that it can definitely impact on people's decision-making process. And there are definitely different attributes that people prioritize when they do think about different perspectives as well. Okay, moving on to the next slide. Okay, so moving on to the impact of choice task formats. Next slide, please. So there were 2 different types of choice tasks that respondents could see. So this included Layton scale DCE choice tasks. So this is where we just have the health dimensions from the health-related quality of life instrument. And then we had choice tasks with duration, which includes an extra attribute specifying the number of years that their health state will be experienced for before dying. So for instance, in this slide, we see that health state A is experienced for 10 years before dying, and health state B is experienced for 8 years before dying. Okay, next slide. So in terms of what respondents were thinking about and prioritizing in their minds, a clear theme that emerged from both the adolescent and adult sample was a clear preference for prioritizing quality of life in many instances, even when it came at the expense of a shorter length of life. For instance, we have one quote here, a 13-year-old male that says, if you're in pain, why would you want to live longer? So quality of life was quite important to many respondents and in many of the choice tasks as well. Next slide. It was also important to note that for parents, family or children became a key part of the decision-making process. So respondents would think about prioritizing length of life to spend more time with children, but we also have some parents that said that they will prioritize a better quality of life at the expense of a shorter length of life in order to spend quality time with their family as well. Next slide. So for the adolescent sample, the majority of times when they were choosing between the choice tasks, quality of life definitely was a key driver of decision making. But we definitely had one or two instances where some adolescents did prioritize length of life at the expense of worse quality of life. So some would prioritize because they want to spend more time with family or friends, or just because they wanted to live longer. Next slide. And when it comes to thinking about a latent scale DC choice task versus choice task with duration, many people said that having that extra duration attribute did actually help them think about what was most important to them. It helped them to prioritize better and to provide more context for their decision making. Okay, next slide. So now moving on to the impact of using different health-related quality of life instruments. So we had 3 different instruments that we used. So this includes the EQ5D-Y5L. So that includes 5 dimensions that respondents had to consider. Next slide. This also includes the CHU9D, which has 9 attributes for them to consider, although these were shorter in length. Next slide. And we also have the HRQoL3, which has 8 attributes in total. And as you can see, this was quite a lengthy attribute levels. Next slide. So in general, so in the pre-planned questions, after they completed everything, respondents were asked which instrument would they prefer to complete as a survey online, and the vast majority of respondents said that the EQ5D-Y5L was definitely their preferred instrument in many of the circumstances. Next slide. It's also important to note that many respondents felt that the HRQoL3 was quite a difficult instrument to complete as choice tasks. It was considered quite wordy and lengthy, particularly among the adolescent sample. Next slide. But in saying that, there were also some respondents that did say that the CHU9D and the HRQoL3 actually made it easier for them to imagine the choice tasks because there were so many more attributes to consider, because it was wordier, it gave them a better picture of the choice tasks and the health states, even though it didn't actually make the choice any easier. Next slide. So now moving on to next steps in discussion. Next slide. So in summary, in terms of what we found from the first 58 interviews, in terms of these particular points, there were definitely more similarities than differences in how adolescents and adults value DC choice tasks. In particular, it was found that for many adolescents and adults, quality of life was definitely a key point for consideration. Adolescence was found to be able to understand and complete DC choice tasks with duration, which hasn't really been shown before in previous studies. And the EQ5D-Y5L was generally a well understood and preferred when it comes to completing online as DC choice tasks. So from these findings so far, it seems that it is feasible to definitely generate value sets from adolescent populations. And is something that is explored further in Project 4 and 5 as well. Next slide. Project 3 is ongoing. So we currently have completed round 4, and we're currently conducting round 5 of interviews. So this is much more focused around how to best present choice tasks to respondents, specifically focusing on the EQ5D-Y5L. And at the end of this year, we will have conducted 94 interviews in total. Next slide. So thanks so much for listening, and I'll pass it over to Tessa, who will be talking about Project 6.
Thanks, Alice. So I'm going to give a sort of overview on behalf of the large Project 6 team, looking at the PTO study comparing gains to children's health to gains to adults' health. Next slide, please, Kim. So as Nance mentioned at the beginning, we started this project looking at what was known already, and there is this systematic review that's about to be published in Pharmacoeconomics. And what we gained from that was some of the gaps in the literature. Thanks, Kim. And some of those specifically were a lack of evidence on understanding the relative weights for the very small children and adolescents as they progress into young adulthood. There was also gaps in terms of understanding why it was that we found the different methods seemed to give different weights for the importance of children. So although on balance, it seemed to be the case that there is a desire to give additional weight for children, there's quite a few remaining uncertainties. And it was those uncertainties that we were trying to explore within this project. Sorry, Kim. So one of the other things was the extent to which the weights were the same when we were looking at improvements in quality of life compared to improvements in length of life. So we kind of tried to tackle all those gaps by conducting a large person trade-off study. Next slide, please. So within a person trade-off study, we're asking respondents to conduct a choice task, but we're really focusing in on the key aspect that matters, which is, in this case, the age of the group. So we set up a context of asking respondents to think of themselves as a social decision maker and ask them a series of questions of which program they thought should be funded, where the difference between the programs was the age and then also the number of the patients that gets treated. And so we can ask iterative questions to respondents to try and find out a point of kind of equivalence or where the two programs match. And then we can use that ratio to indicate the relative weight that people place on treating patients of those different ages. Next slide, please. So within the study, we had a kind of number of objectives. Firstly, we wanted to get a weight across all of the different age ranges, going right from 1-month-olds and 2-year-olds, the very small children where we felt there was a lack of evidence, all the way through to 24-year-olds who, although we might not label as children, they're certainly young adults, and we wanted to understand that transition into adulthood. And we chose 2 adult weights to compare the findings to, 40-year-olds and 55-year-olds. The reason for that is that we knew from the literature, if we used an older adult age, respondents would definitely prefer the children, but we weren't so sure when it was a younger adult age, particularly an adult age where the adults might themselves have caring responsibilities for young children. Other objective was to explore different scenarios. So we chose 5 different scenarios, 2 different lengths of life, and improvements in mental health, physical health focusing on mobility, and physical health focusing on pain. Additionally, we wanted to explore some of the methods issues in conducting PTO studies, and so we ran the study with one arm being offered the chance of saying they didn't want to age weight, so we gave them an indifference option in the choice task, and one arm where they were forced to choose. So next slide, please, Kim. You can see that the kind of questions that they were given was this program A versus program B. Half of our sample were also given a choice to say no preference, and half weren't. Next slide, please. So for the averaging of PTO results, we're dealing with ratios which don't have very nice properties. And I know it's not a math lesson, but I just want to explain a little bit about why dealing with ratios is a little bit tricky. So on this table here, we've got an example for respondents, and they've given us a person trade-off response for X and Y, which could be, you know, aged 5 or an aged 40. So for our first respondent, they actually prefer Y. So treating 50 patients of age Y is equivalent to treating 100 patients of age X. So the ratio there would be 2. And we could take a mean of all those ratios. Now, next slide, please, Kim. If we switch that round, and instead of saying X to Y, we say Y to X, we would expect it to be symmetrical around 1. So given that the mean was 1.375 of that, we'd expect it to be around 0.6 something. Unfortunately, it's not, because ratios don't have a symmetrical property. So we can't use the mean of the ratios as our kind of average. Next slide, please. So what we have to do is take a few different measures instead. And one which is commonly used is the ratio of the means. And so what we do there is we take a mean of, in this case, it's kind of X star, which is where we are putting a 1 every time somebody has that age as the preferred age. And then we take a mean of all those scores and we take a ratio of the means. That way, we end up with something that is symmetrical around 1. So if you can see on the slide where it says the ratio of means at 0.9667, that's symmetrical to taking it the other way around. Okay, so we have nice properties there. But we also might want to kind of think a little bit about the distribution of the ratios, and often that it's not a very nice normal distribution. We get a big peak in the middle of people who don't want to age weight, and then we get a kind of tail either side of people who want to age weight for adults, people who want to age weight for children. So we've also explored the medians, and we also explored the geometric means as well, both of which have neater properties when we're dealing with ratios. And we've also kind of looked at uncertainty using bootstrap methods. But what I'm going to focus on today is just the ratio of the means, which is possibly our most preferred measure of the central tendency. So our sample that we had, it was an online sample. We had a considerable amount of dropout because we forced people to watch a video of 6 minutes. And actually, we think that that was important, that they really understood why we were doing the study and how to approach these person trade-off questions. We had some inclusion criteria, and we did lose people through that, but the inclusion criteria was fairly reasonable. It was kind of, did they report consistent age? Did they correctly identify an attention check question? We also re-included people if they really showed us in the open text response that they had engaged carefully with the person trade-off studies. Running alongside the online data collection, we also had 41 qualitative interviews where we wanted to really explore how people were approaching the questions and the kind of reasonings they gave for their prioritization choices. So in total, we had a sample of just over 2,000, which was really quite closely representative to the Australian population. The only one aspect where it wasn't was in whether or not people spoke English at home as their first language. Next slide, please. So I'm just going to give you some of the kind of headline findings, and this is focusing on the ratio of mean results. So on the left-hand side of the screen, you can see aged 40 comparisons in blue and age 55 comparisons in color orange, sorry. And that's for when we didn't force people to make a choice. So it's unforced because they had the option of saying that program A and program B were of the same social value. And that bold red line is representing 1. And so that's where they give equal weight to the adult, the 40 or 55-year-olds and the different child ages. And what you can see is that for the tiny babies and tiny children, people prefer to treat the adults. But then as our children get to 6 years and above, all the way through to 24, they prefer to treat the children. On the right-hand side of the screen, you can see there are same responses, but for when we forced people to make a choice. And what you can see is particularly for the 55-year-olds, they more strongly prefer treating the children. Now, in our original kind of protocol for the analysis, we were going to combine the forced and the unforced as long as they were similar. Unfortunately, we didn't think they were similar enough in order to be able to combine them. So we decided to focus most of the attention on the unforced. And that was partly due to the fact that in our focus groups that we ran to discuss the findings that we had to help us with the interpretation, although members of the focus groups were fairly happy with asking people a forced type choice, they were happy because they felt that if that was something decision makers had to do, then it was reasonable to ask the public. However, we didn't really assume that decision makers had to age weight. So on that basis, we kind of prefer to give people the chance not to age weight, because it's a perfectly legitimate response not to want to age weight in favor of any age. Next slide, please. So this is just the unforced response. This is the adding on the scenario of 5 years. Before I just showed you 2 years of additional life. And you can see when we change that to 5 years, actually it makes very little difference. Next slide, please, Kim. The next line, which has been added on, is a kind of grey line, and it is improvements in mental health. So distress and low mood. And you can see that tracks fairly similarly to additional years of life. Again, we can see that people are giving less weight to the tiny children, which in our focus groups, our respondents felt was because actually people didn't have a very clear conception of what poor mental health would even mean for those very small children. And you see we also get a kind of unexpected peak at 14, which again, our respondents put down to the fact that they're very aware of the importance of mental health for teenagers. Next slide, please. We next have the mobility weights added. The yellowy line is the mobility and the green line is for pain. And what's interesting with the pain is that we can see we get an additional weight for every single child age all the way through to 22. And so we get quite a different pattern appearing in the very tiny children, where although people don't want to give additional weight for years of life, they very much do want to give additional weight to children when it's pain alleviation. Next slide, please. We also asked some attitudinal questions around, more generally, just a simple comparison of child versus adult and quality of life improvements and length of life. So we've taken away some of the detail of the questions. What we find here is that most of our respondents select the option that priority should be the same regardless of age. And that's both for length of life improvements and quality of life improvements. And when we asked them if they thought it would be fair if we prioritized children in terms of willingness to pay, we found very split responses. Next slide, please. So our main findings from the PTO work was that respondents do give greater weight to child health gains when the children are over 4 compared to 40 or 55-year-olds. But the attitudinal questions find that a majority are not in support of that simple additional weight when we describe it as a child versus an adult. And under 4, we find we get less weight for life extension and mental health gains. And our greatest weight overall is for pain alleviation, where it's over 1.2 weight for every age up to age 16 across all our different forced, unforced, and different ways of looking at the aggregate that I described earlier. So we do have some pro-child preferences, and they're particularly strong when we compare to a 55-year-old compared to a 40-year-old, as we might expect. Next slide, please. Very, very briefly, the qualitative work is very rich in terms of understanding why people made the decision and the processes they were thinking about when answering the PTO questions and the attitudinal questions. When it comes to thinking about extra years of life, a lot of our respondents were very focused around awareness of death and the dying process. And they were also very focused on what is it that individuals will be able to do with their time if we are giving them extra time. Similarly, when they were trying to think about the impact of the health conditions by age, they were really thinking about the detail of what would that actually mean in terms of somebody's well-being and quality of life. Many respondents thought carefully about the impact of a health condition or loss of life on other people and on society, both on the parents of the children who had the health condition, but also the children of the adults who had the health condition. And many respondents were also concerned about fairness, both in terms of a very small percentage raised issues around proportion of time lived. Most of the fairness issues were around providing equal treatment to everyone, regardless of age. Last slide, please, Kim. So in conclusion, we found really varied and diverse views. Some people were very happy to strongly prioritise children. Some people strongly prioritised adults. Some people thought there should be no preference. And some people even resented us asking the question about age weighting. The justifications for people's responses are really varied. When we ask the very simple child versus adult questions in the attitudinal questions, we find quite a different level of support to when we ask the choice questions, person trade-off questions. We do find some support for child weight, particularly in relation to alleviating pain, where we could clearly argue for a weight of about 1.2 to be placed on treatments that alleviate pain. Thank you very much. I think we've got a little bit of time for questions, have we?
Yeah, thank you everyone for such fantastic presentations. That's been really great and such a huge body of work that's been presented. I think we've got one question in the chat that hadn't been answered from Bernarda. So I don't know if anybody wanted to answer that to kick off the discussion. So Bernarda had said in a previous webinar on hearing loss, she reported quality of life according to disability weights from the global burden of disease. Is there anything that could be said around the possible use of HRQoL for hearing loss with onset in infancy and lifelong disability? So I think that would be going back to the presentation, was it from Kim?
Yeah, I mean, I think if you're talking about the sensors, the HRQoL really is the only instrument that in our suite of instruments that does include specific questions on the sensors. So I think she's absolutely right that that's really the only option if the intervention is targeted at something that would affect hearing. So we don't have a lot to say about that other than I would agree with that the HRQoL does include that dimension.
Thanks, Kim. And then we've got another question saying for Alice, that getting a little bit confused around the pilot round. Does the pilot aim to test something? So should we drop the data of the pilot round out of data analysis?
Oh, thanks for that question. So I think that was just more a wording problem that probably confused people. So I guess I named it just the pilot just because it was the first round of interviews that we conducted, but we did recruit a proper sample, if that makes sense. So I think normally people think of a pilot as, you know, testing on a convenient sample or some family or friends, but that was actually, we used real respondents for that. Yeah, like I feel like the data was still quite valid in terms of the first round of respondents that we collected. But due to the nature of how we're doing this, each round we do make changes. So it is expected that each round there will be some slight differences. But so it's more of a wording issue. I probably should have just renamed it to round 1 and then gone from there. I think the naming it pilot just confused people. Yeah, so thanks for the pickup.
No, that's okay. Thanks, Alice, for the clarification. Does anyone else have any questions? You can feel free to. I think you're allowed to switch your microphone on, or of course you can post anything into the chat if you'd rather. Stavros.
Oh, thanks very much for the presentations. It was a really, really interesting set of presentations, so thank you. I wanted to ask a question about the multi-instrument and comparison study. And it was something I've been thinking about following a systematic review that we did that compared the psychometric properties of a range of childhood multi-utility instruments, multi-attribute utility instruments, and it's around the tests of responsiveness and whether, I mean, I guess what I'm wondering is whether, to what extent are the differences in effect size driven by the differences in the underlying ranges of utility scores that are available for each of the instruments. I don't know if you're able to sort of disentangle that.
Yeah, that's a really good question, because I think that the full range of the utility scoring will definitely have an impact on responsiveness. I didn't clarify that the results we presented today were only on the level sum scores. So I guess we are seeing that without the impact of that utility range, but it will be, that's sort of our next step, but it will be important, I think, to look at it in both steps, on the level sum score and then again on the utility, because there's going to be different things happening at each step. So I think what we've shown you today is without that extra complexity. But I guess it introduces new limitations, which is around how well a level sum score is really differentiating things that change for children. So yeah, different limitations, but it's a great point.
Thanks.
One thing we're quite mindful of, Stavros, and from the joint review that we did around childhood proms, is how different the characteristics are of the value sets across these instruments. I mean, they have completely different properties in terms of scaling, in terms of the relative importance of similar health problems, etc. So I have no doubt that the application of utilities will introduce an exogenous source of variance into analyses and comparisons of these data, which in part is why our first suite of papers from the PMIC study have really focused on the descriptive system and sort of digging down into item, dimension level. We have, there are existing value sets. There's also a new value set for the Y3L about to be completed. That's not got anything to do with QUOKKA. That's from another source. And we're working on a Y5L value set. And we already know that we can see some differences even between those value sets. So I think it is quite challenging. We know that different sets produce different results. So
And the other thing we've been learning, which may be obvious to everyone, but when we step back from the measurement and the valuation studies, I guess we're seeing quite a lot of points where that exogenous variation comes into estimating child quality of life. So the switch from proxy to self-report is another point that it comes in. When you switch from an instrument to another instrument, when you switch across age, and then the valuation adds another point of endogenous variance. And I think that's going to be really critical for decision makers to understand each of those points.
Thank you.
Yeah, so I feel really mean to say that we're kind of out of time and we're going to have to draw a close. But I was going to say, if anybody wants to stay afterwards, I'm sure we can have a bit more discussion. But just to officially say thank you to all the speakers for such fantastic presentations and such a huge amount of really impressive work. Thank you so much for sharing it with us today, and thank you for everyone's questions. I think if anybody wants to stay on the line, we can do to carry on some discussions afterwards, but I realise some people might need to get off.
Thank you.
I've got a question if I can, if I'm allowed, even if we're out of time. It was to Alice. So I know that you'd got obviously different people included in your interviews when you think about the DCE. So you'd got some adolescents, and then you'd got sort of younger adults, and then you'd got sort of more older adults, but the really older adults seem to be missing from the sample. Did you find anything different when you were thinking about sort of the different subsets of participants in terms of maybe what they were thinking about, or how they were finding some of the tasks, or some of the things that they found easier or harder? Was there sort of anything that was coming out from the work that you've done so far?
Sorry, I just muted myself. Yeah, so I guess like we were thinking more in, rather than age, is more for the adult sample, making sure we had some parents and non-parents, so we weren't too focused on whether we got a good range of adults between the ages of 18 to 80, for instance. So our focus was more on the parents versus non-parents. And yeah, I feel like there are some slight differences between the parents and the non-parents in terms of their responses, just because parents would definitely refer, a lot of them will refer back to, oh, because I have children, I would prefer this. So there is that kind of reasoning that comes into their thinking. And also interestingly, originally we've tried very hard to recruit between the ages of 12 to 14, just because we have, in the earlier rounds, we noticed that there was kind of a difference in thinking. And certainly for the younger age group, we were concerned that perhaps they may not understand the survey, and we definitely wanted to include them to see if they could. So I think there was one that found some of the concepts a bit challenging. But there were also some like 13, 14-year-olds that, really weren't that different from some of the older adolescent sample. So it's about the level of maturity as well, I think. So it's really hard, because I think it's easy to think about breaking it down to age groups. It's just what we tried to do. But then later on, we kind of realized, the level of maturity actually really plays an important role as well. Yeah.
Yeah, I think it's also hard to know that because would you be recommending for the later stage that it would be online DCE, or would it still be with an interviewer present? Because I guess that's the difference as well.
I mean, from what we found, generally the adolescent sample was able to complete the questions like quite competently. So I can't see why we couldn't complete them online. If you're thinking about distress, we were definitely prepared. We were actually expecting perhaps maybe some of the adolescents maybe a bit distressed about what we were asking, but we certainly didn't see that, which we were actually pleasantly surprised about. And actually in many cases, a lot of them actually wanted to stay on to keep talking about it. So, because it was only meant to be a 30-minute interview, but many of them just stayed on because I guess many people don't talk about these kind of issues with them. And, many of them were really quite happy to talk about this.
Thanks. So I think we've got a question from Tracy.
I just wanted to come back on something you said about age. I was interested, first of all, I should say it's an amazing amount of work. I just got lots of questions actually, but I just wanted to ask about age, and because both in terms of how you do the analysis, so you seem to group quite broad range of ages, and how you decided those age ranges for the analysis, and then also why you chose a 10-year-old child as the reference age in the thing, and whether do you think it would make any difference if you used a different age there or not?
So I might leave the age question to Nancy, actually. We had a lot of discussion about what we should use for the age, and I think that's always something for discussion about which age we should use. But the short answer, I think it's what HRQoL uses. But I think we did consider other ages as well. And in terms of recruitment of the age groups, I think the main thing was we wanted to understand young people. So obviously that covers quite a broad range of ages. So I guess in terms of our recruitment strategy was trying to get a broad range of ages between the ages of 12 to 17. We wanted to perhaps recruit younger, but it was already quite difficult just to get someone at the age of 12, for instance. So, you know, it would have been nice because the pediatric instruments we were looking at did cover some people that were younger. Technically covers people a bit younger, but it was already quite difficult to recruit people that were less than the age of 13, for instance. Nancy, would you like to add?
Yeah, sure. On that 10-year-old, you know, why ask adults to give their views about a 10-year-old child? I mean, it does seem a bit arbitrary, doesn't it? And you know, for the EQ5DY, I think that was selected partly to do with the range of ages covered by the instrument. There has been experimental research to see what difference it makes if you change that age to ages lower within that covered by self-report on the descriptive system and older. And I think, oversimplifying possibly, but I think what the evidence on that shows is that for latent scale DCE, it actually makes surprisingly little difference at all what stated age is there, but it does make a difference for TTO. So interesting to think how that could have played out with respect to DCE with duration. There's such a bewildering large set of methodological questions facing research around paediatric utilities. And Donna and I, and Kim as well, and others are working on an ISPOR best practices task force on paediatric utilities. And yeah, it's really quite a challenge. There's so many options.
Thank you, that's really interesting.
Did anyone else have any questions? Can I ask one question to Tess? I do realise she's my colleague, so I can ask this outside the. But I was just wondering, because obviously a lot of the results when you found them weren't they weren't hugely different to the line at 1. I mean, they were, don't get me wrong, but they weren't huge. Was there anything you can do to test whether they're kind of significantly different to 1, whether there was anything that could be done to see when it was that they were kind of so much larger that you'd start to say that did seem important, or anything around the proportion of people that were saying something that was swaying it, or anything along those lines?
Yeah, one thing we have done is put a kind of confidence interval range around each of the results just based on the bootstrapping, but we've just used a kind of 95% percentile of the bootstraps to show that. So you can see that in almost most of the comparisons that doesn't cross over the 1 line. But we do see quite a lot of variation. So and we see variation if we take the median, which often comes out as 1 for many of the comparisons. You know, although the sample was 2,000, it ends up being quite a small sample for each individual age comparison. So they're split in terms of forced and unforced in the arms, and then they're randomly split to just 1 age comparison. So we get fairly small samples. I mean, there's a number of things that we are looking at, because we were looking at kind of combining some of the ages, so combining aged kind of 8 and 10 and 12 and 14 to kind of smooth out some of that noise. But I think the main thing is we don't want to kind of rely too heavily on any kind of single number. It's what we're really looking for is kind of what's the take-home policy message, where we could be really confident in making any recommendations. And I think pain is the one where, you know, we see a kind of very consistent finding across all ages of children. So that's, otherwise just simply relying on a statistical test, I think it will be useful, and it'll be useful in the paper to see the confidence intervals, but I think we don't want to kind of rely too heavily on a single statistical test of the ratio of the means when we are actually trying to draw on a lot of other information to see if there's a kind of democratic remit for the weights. Does that answer your question, Laura?
Yeah, it does. Yeah, thank you.
Yes, I wonder if it's worth sort of noting some of the synergy between the different results we get from different aspects of these studies. So it's really interesting that pain comes out in that way in the PTO. And the other thing that we note with valuation studies, typically in EQ5DY anyway, is that pain is nearly always, when adults are asked to value pain health states in a child, nearly always comes out at the top. So there seems to be something about pain, right, when adults are thinking about pain in children.
And in the measurement too, Nancy, so when we drill down on that responsiveness data in the very sick children, it's the pain dimension that's driving the responsiveness in the measurement as well. So pain's featuring across all of our pieces of work in a really similar direction. Yeah.
You're on mute, Donna.
Sorry, I was just going to say that sounds like a really nice theme throughout, doesn't it? Then that it kind of joins it all up. If there's no more questions, then I'd just like to say a massive thank you. It's been so interesting. Thank you so much.
No problem. Thanks for having us. Yeah. Thanks, Di, for your help too.
Thank you.